iEcho is hosted locally by the, sorry, get rid of that, by the Gastro Foundation, and in support, supported by the New Mexico University. And we have weekly sessions. This week is pediatrics, and we are very, very pleased to be able to welcome Zeenat Gaibee. Zeenat is a local yokel. She cut her teeth here. You might have seen in the advert, she did her undergraduate training at Stellenbosch University and postgraduate pediatrics and pediatric gastro training at the Red Cross War Memorial Hospital. So Zeenat's then gone overseas, and she's currently in a research unit in Toronto at the Sick Kids. And her research passion is very early onset IBD, which is something that I think we all have a few patients lurking around that really started their IBD very early on. And we look forward to hearing from Zeenat what we should be doing, because at the moment we really don't have much in terms of immune testing and mutation testing that we can offer. So thank you, Zeenat. We were very happy to catch you after our disastrous start in August at the SAGES conference. And yeah, take it away.
Thanks, Tom. It's very nice being amongst South Africans again and hearing the South African accent. Definitely resonates pretty well. Let me just try and share this again. I think you can see my screen.
Yes, we can.
Okay,
okay, perfect. And okay, so it's perfect. So, I mean, as many of you know, IBD is definitely moving into a more of a pediatric disease. While in South Africa, it was predominantly found in our adult population, and training has definitely been a little scarce in terms of adequate pediatric IBD notion, which is one of the reasons why I've come over to Canada, just to get a bit of a better stronghold. What we see as a global trend is that IBD is found more and more in your pediatric population, with more advanced diseases going into adulthood. And this is particularly true in the center that I'm at. So at the moment, I'm based in Canada, which has one of the highest rates of IBD in the world. It has an increase of about 50% over the past decade, and particularly in the young children, those aged less than 5, has had the biggest increase, which is not uncommon in more advanced or more historic IBD populations like Western Europe and Northern America, who have IBD for a much longer period than some of the lower middle income countries. This is the trend where you're seeing more very early onset. That is true, however, for South Africa too, as we've seen quite a number of cases, just anecdotally. So the center that I'm at is called Sick Kids, one of the leading centers here. And if you look at the trend over the past few years, it's a little bit outdated. Currently, they're seeing about 200 new cases per year, with over 2,500 cases chronically being managed just within this pediatric hospital. And this is one of many within the province. So it's definitely a huge concern here, and a lot of research has been going into it, billions of dollars being invested, and so we are reaping those effects. And even though we don't really have good stats for South Africa, I'm hoping through many of these projects we'll be able to now get ourselves on the map and represent ourselves. The adults have been doing a better job of it than the pediatrics, but hopefully we'll see the change soon. So what is VEOIBD? I mean, there's quite a number of terms, and for our adult colleagues, you may hear a number of them. There's PIBD, which is often just a blanket term for pediatric IBD. There's very early onset IBD, which is a more commonly used term, referred to those less than 6 years of age. You may come across early onset, which is supposedly less than 10. This is a phrase that's kind of been moved out. And then your infantile onset, which is those having symptoms of IBD in the age of less than 2 years old. And you'll see over the years, it doesn't project very well, there's been a massive increase in what we understand in terms of very early onset IBD and its causality and its different monogenic forms. So what makes VEOIBD quite unique? Well, it's a little bit different to managing your adults because there's a number of caveats that need to be taken in mind. It's also a little bit different to managing your adolescents, which I feel is more of an adult kind of phenotype. Your younger child is has a little bit more aggressive management, and then your VEOIBD is a unique group because they often have different etiology or more defined etiology rather than the polygenic forms in adulthood and adolescence. So growth failure is an important feature. The BMI is not as reliable as that is used with adolescents. So we usually use the height as a Z score. Disease location is often mostly found in the colonic area and very infrequently found as ileal disease. The histology is pretty unique because there's often cases, degrees of apoptosis, duodenal blunting, and eosinophilic infiltrates. And apoptosis being quite a marked feature in terms of helping us with our diagnosis. And then the response of therapy is probably what gives most of us as clinicians the greatest difficulty. So drug monitoring is essential, more aggressive treatment is essential, and dosing using body surface area. And there's a number of studies, which time will not allow me to present, showing the value of doing body surface area dosing rather than weight-based dosing, particularly in this under 6 age group, to get great target levels. So drug monitoring in this group is really essential because it often needs higher than the standard doses for this young group who metabolize pretty fast. And then genetic and immunological considerations are really important because often there are immunological backbones to it. And then this little graph in here is just a reminder that we often use fecal calpro as a marker of inflammation, and it's useful in your adults and your adolescents, not as useful in your infants because this was a Finnish study that looked at healthy controls, and the baseline fecal calpro in healthy controls in those aged 1 to 3 actually sits around 350. So just to keep that in mind when you are thinking about your patient and how to use it. It can still be used, but just with a bit of discretion. So how does the workup go? Well, it's a little bit different as well. The standard things are still standard and essential. Patient history, particularly family history, becomes essential. History of consanguinity, thorough examination, which South Africans have no problem with at all. But then in terms of your chosen investigations, it goes a little bit beyond just the lower and the upper endoscopies and your inflammatory markers. Thinking about your differential within your CBCs, looking for signs of neutropenia or lymphopenia. All cases below 6 are required to have a neutrophil oxidative burst test or a NOBI. This is essential in making the diagnosis of CGD, which often can mimic your IBD picture or coexist with your IBD picture. And treatment modalities are then very different. Doing an immunoglobulin profile to be able to look for common variable immunodeficiencies and agammaglobulinemias, and then lymphocyte subsets looking for SCID. This is usually your first standard part in managing a patient, less than 6. And if it hasn't yielded much, then looking a little bit deeper in terms of FOXP3 and IL-10, which are actually available in South African labs if you look for targeted diseases like IPEX and IL-10 receptor defects. And then there's the role of genetics. So what we're finding is that the earlier the genetic screening happens, and at the moment there's a British adult gastroenterology and pediatric gastroenterology paper that's been published talking about the role of clinical genetics and when to use it and when not to use it and which settings. So for the adult colleagues, it's maybe a bit more useful, but those managing children less than 6, this is definitely not just a research tool, but a clinical tool now. So just going through these processes already, you start thinking of different etiologies. There's about 100 IBD genes and about just 70 congenital diarrhea genes, which often overlap if you're looking at that infantile population. So remembering them all or trying to pass them all is often a nightmare, and having access to being able to view those may also be limited in our settings, but just going from our history and our endoscopic findings, we're able to get a bit of a better idea of your hyperinflammatory defects. Looking at your immunoglobulins and your vaccine titers gives us an idea more towards a antibody or combined B or T cell defects. Doing the DHR or the NOBI gives us an idea of oxidative stress function and looking at CGD forms. And then going on further to look at cytokine panels will give you immune dysregulation. And then if you still haven't found anything at that point, then specific screens with whole genome sequencing has been found really useful. So is this really an issue for adults? Is it just for a kids issue? Well, the Oxford group with whom Oleg did a review on an unbiased IBD population of about 1,600 individuals. And they looked at the genotype, phenotype conditions. And what they found is that there are milder forms of IBD expressed genes in your adult population, although many of your adult onset is between the ages of 20 and 30. There are milder forms that go undiagnosed, or there may be childhood onset, which may have been underplayed and exacerbated later, or may just be a moderate disease process and never really sought help managed as an IBS component until much later. So it's a pretty complex idea, and this is a really busy study. It's not slide, and it's not meant to be interrogated, but just to give you an idea of the complexities that are involved in terms of trying to get to our diagnosis. So let's just get a bit more clinical. Let's start off with the case. So we have a 5-month-old baby girl presented. This is one of our neighbor centers. So she presented with diarrhea, fevers, and you can see MS is a North American thing, and vomiting, failure to thrive, rash, and splenomegaly. Her lab findings had leukocytosis, some anemia, and she had inflammatory markers in the CRP and ESR that were elevated. Her ferritin, LDH, and transaminases were all elevated. And she was actually pretty sick when she initially came in and admitted to the high care and ICU units at some point. Eventually, she ended up having an endoscopy, and figure B shows just some ulcerations in the stomach, duodenum, and colon. That's the colon. So it's a very non-specific finding, but this macroscopic red erythematous areas with isolated ulcers. Pathology then showed villus atrophy, crypt abscesses, and signs of chronic severe colitis. She was a very difficult patient to treat, didn't really respond to high-dose steroids. She started on infliximab, vedolizumab, and they had started cyclosporin, not something we use very often, but with a very ill infant, is understandable. So after much ado, they were able to get rapid genetic sequencing. This rapid means within 2 weeks. It's not as thorough as your whole genome sequencing, but gives you quite a good idea. And what they found was a de novo mutation in NLRC4, which is a key component in inflammasomes. So essentially in the normal state, you would have activated some trigger like infection. And then after cleavage, you should have produced IL-1 beta and IL-1 18. And once that's all cleared up with an infection, she should have stopped the production of cytokines. But because of this mutation, essentially she was just pumping out IL-1 beta and IL-18. And so having this genetic diagnosis, they were able then to utilize this information to understand what her body was doing and applied targeted therapy using an IL-18 blocker, which at that point was compassionate use. And then later an IL-1 blocker, which is canakinumab, which is actually available to the rheumatology group within South Africa as well. And as you can see, she showed complete remission and is still doing pretty well from what I understand. The next case is a 17-month-old who presented with recurrent fever, intermittent blood, and stool. His past medical history involved quite a number of serious infections, including severe pneumonias. Clinically, he had some hypertelorism and epicanthic folds with some low-set ears, and his colonoscopy showed essentially a pretty flat duodenum with colonic ulcers. Histology showed duodenum paucity of plasma cells and chronic active colitis. So still very non-specific symptoms or findings from that histological point, but quite a significant clinical picture. They went on to do immunoglobulins, and you can see there's quite a marked decrease in your IgG and IgM levels. He also had low titers vaccine responses, so low titers to diphtheria, tetanus, and pneumococcus, and he had no switch to memory B cells. So he also had a genetic testing done as part of your clinical care, and he was found to have a mutation in ZBT-B24. Essentially, this is a causal defect in central immunity. So he was started on IVIG and has actually done really well and had remained in complete remission. So these are two very different cases, but it just highlights how having the genetic diagnosis was really helpful in the scenario in terms of being able to use targeted treatment and in a patient would have been otherwise really difficult to manage. So what goes on with IBD? Well, it's quite a complex condition, as many of you are already privy to. But we talk about 5 main categories in terms of our disease profiling. So your primary epithelial defects. We know that this is your first layer of contact with the external environment, your phagocytosis and chemotaxins, and your adherence molecules. Then you have your regulated defects, T cells, your defects in cellular and humoral immunity, and then your autoinflammatory group, which is more of an HLH kind of picture. And all of these areas work coherently, but may also be targeted in terms of causality. So let's go clinical again. We had a 1-week-old baby who had baby boy, had failure to thrive, had abnormal respiratory pattern and diarrhea. He had multiple hospitalizations and ER visits for diarrhea, vomiting, lethargy, dehydration, and metabolic acidosis. Clinically, he had quite a coarse facial features with woolly hair and severe perianal rash. And for those of us in South Africa, those would be a typical kwashiorkor baby. But this wasn't. It was a good socioeconomic case background. He was seen multiple times, and by the age of 5 months, he made it to a gastroenterologist who then did a colonoscopy and found mild scattered ulcers in the colon with inflammation, and his pathology showed eosinophils, apoptosis, panel metaplasia. So this presentation is actually quite characteristic of an intrinsic epithelial defect. And because this is your first line of defense, they often have a typical phenotypic picture. So diarrhea may either be bloody or watery. There's often esophagitis. They can present with obstruction or recurrent blistering. There's often electrolyte abnormalities or metabolic acidosis and hyperalbuminemia. And they can be associated findings in the hair, nail, teeth, skin, and hearing loss. So anywhere that you can find epithelial cells, anywhere there's epithelial cells can have manifestations. So this trial went on, and the endoscopic findings can be quite varied as well. So it can either be a panenteric or pancolitis type picture, or it can have isolated colonic disease. But often in the histology, you'll find apoptosis and apical distortion, particularly with cell metaplasia. What's really nice about this is that there are therapies that have been discovered and therapies that are available to us in South Africa. So things like rapamycin and leflunomide have been shown to do quite well. And the lab that I'm working in, and one of the projects I'm working in, has to do with TTC deficiencies. So this is both epithelial and an immune-mediated gene that affects your teeth, that causes diarrhea, but can also cause atresias. They did quite a lot of disease explanation and elucidation, and we've worked with zebrafish, and currently we're working on the high throughput model looking at leflunomide, which has shown great success in zebrafish, and now currently undergoing trials in children. So if any of you have a case of TGT7A, please let me know so I can add it to our data set. But this just shows the value of being able to get a diagnosis and try and work through precision medicine in terms of trying to find your best solution for your child. The second case is one of recurrent infection. So 3-month-old male presented with fever, elevated inflammatory markers, and elevated LFTs. He was shown to have hepatic abscesses, and a week later developed perianal abscesses. His neutrophil burst test showed an absent neutrophil burst test. This is highlight for CGD type of picture. And so he didn't have whole exome, whole genome sequencing, but had a targeted panel, and that was characteristic for CYBB. And he's actually currently scheduled for a stem cell transplant, and they actually do really well on stem cell transplant. Just a management note, what we often use while we're awaiting the stem cell transplant is vedolizumab, just because it has a local effect rather than a systemic effect, because as you know, many of these defects have an innate immunity component. So immunosuppressing someone with CGD or any of the NSF receptor blockers, you're actually going to exacerbate the disease. So having this information readily available to you before starting a biologic is really important. And if we really need symptom control beyond a 5-ASA, then vedolizumab has been shown to be pretty safe. What about the polyautoimmune diseases? So now we have a 15-year-old, so closer to your adult group, and more relatable. So she was a 15-year-old female who was diagnosed with ileocolonic disease. She had failed multiple therapies, and over the years had developed a number of autoimmune comorbidities, including thyroid disease, alopecia, and lung disease. And she was seen at our clinic only at the age of 18, where she was discovered to have a CTLA-4 deficiency. So CTLA-4, as many remember, is a key regulator in T cells, and essentially what it does is it puts the brake on so that you don't overproduce and go into an inflammatory cascade. There are actually a number of CTLA-4 cases that we managed at 2 that I can remember from Red Cross, but it just speaks to the way that there's different penetrance within different individuals depending on your variant, and while some may present in childhood, there may be quite a number of them presenting in adulthood. There's also a recent publication, which I didn't have time to add to my slides, in a New York study where they looked at LRBA and CTLA-4, and there they were looking at African American population, so they divided them into different ethnicities, and they found a common variant within the African population to LRBA. So there may be a number of these variants that we just are not yet aware of and specific to our African population. So she was treated with abitacept, which again we have available to us, and has been shown to be really useful in the treatment of CTLA-4 deficiency. Her symptoms have improved, and she's actually doing pretty well. Then you have your adaptive, oh, I apologize for the typo, adaptive and regulatory defects, and these are your IL-10R defects. So important to understand this group because there's a number of modalities that can be used. So for your IL-10, we can receptor defects, they do really well with stem cell transplant. Those with LRBA do really well with the abitacept. Those with type 1 interferon defects can respond to interferon modulators, and those with STAT deficiencies will have a different phenotype and often develop or present with short stature, amongst others. So just to highlight that your pathophysiological background does help you both on your phenotype and also in your precision medicine modalities. And then the last group, which is our case 2, case 1 was an autoinflammatory disease or inflammasome group, and this is a phenotype that often presents with what looks like sepsis or an HLH or MAS, depending on if you are internist or rheumatologist type of appearance. And these often have you elevated inflammatory markers and can trigger a cytokine storm. So they often have quite a dramatic a presentation when they do present. Interestingly enough, we've seen a number of these post-COVID, whether it's just highlighting or related, we are yet to find out. So in terms of therapy here, again, there's a multitude depending on which level it is within this very complex diagram. So either stem cell transplant, IL-1 or IL-18 blockades, or JAK inhibitors have been shown to have quite a significant role in this group. So how do we get to all of these modalities? Well, essentially what we decided we undertake is a precision model. So you may think that this may be not within the reach in our South African context, but what we're finding more and more is its clinical utility, and a lot of it being a financial model that's much more economical. So I work in a precision medicine intestinal disease clinic here in Canada, which is obviously funded by more money than a lot of our health budget, but what is interesting to see is that what they do is they take IBD patients and they do your full immunological functioning, these cytokines, there's RNA sequencing, DNA sequencing, and we're able to profile these patients. So they are doing all the profiling, what is clinically relevant and what is more adapted, and what model that we were hoping to move to South Africa and more or less well-funded settings is one where we do clinical genetics. So IBD patients present you, those who are atypical or those who meet criteria for VEOIBD, to be managed as a multidisciplinary team, well-defined phenotypes, well-defined investigations from an immunological point of view, from a T cell, B cell, your NOVIs are done, your vaccine responses are documented, and then your endoscopic findings also very much can be tailored to give you clues as to which group we're dealing with. But the role of genetics really plays a massive role, as you may have seen in the number of cases. Knowing your genetic finding can be really helpful. And we are actually, I'm going to use this moment to do an ad break, but we just have funding now to fund a bioinformatics pipeline through Red Cross and the South African Medical Research Council's Genome Center, where we are able to do genetic testing on any child less than the age of 6 who presents with intestinal disease that's not secondary to infection, allergy, or short bowel. And so what we're hoping to do is profile our African cohort so that we can understand, do we have a similar genotype, phenotype to what's being described in these Western populations? Do we respond similarly to treatments, or do we have variants that are novel and not seen in other populations? And all of this knowledge then contributes to understanding not only the monogenic diseases, but also the polygenic, more commonly found adult groups. So the adults may be wondering why we are laboriously going through this, and is it just a pediatric issue? I wanted to highlight a case that we managed again in the Muse lab, which he's Alex Muse is one of the world leads in VEOIBD and runs a cell biology lab. And we managed a patient who was pretty young, a term baby who presented, who had a fairly uneventful delivery. His dad was adopted, but was thought to be of Ashkenazi heritage. They were non-consanguineous parents, and he presented fairly early in life with intermittent fevers, this typical skin rash that you can see, diarrheal disease, and elevated inflammatory markers. He had these non-specific ear pits and this pustular rash, and he presented what looked like macrophage activation syndrome with the elevated ferritin, etc. He had a scope done pretty early, and that showed a mild colitis in the cecum, was otherwise normal, and thought to be consistent with early onset IBD. He also had a skin biopsy of these atypical lesions, which was consistent with a vasculitis. His CRP was elevated at 200, and his growth was otherwise okay. He was again, before having the genetic diagnosis, was started on a multitude of medications initially because they thought of him as more of a macrophage activation syndrome. He was started on anakinra, then he was then changed to tacrolimus, and he was on steroids for some time. He had nystatin for some time. and he took quite a long time to show any response. But going through his history, we then found that his illness actually began at the age of 2 months. The dad's illness actually began. The dad also had symptoms very early on in life, but never presented because they were not severe enough to warrant treatment. So dad had these non-specific skin symptoms. He also had loose stools and was thought to be more of an IBS type of picture. He had quite a significant bowel history, which he was fairly comfortable with, surprisingly. And because he'd had this all his life, he had repeated ear infections, he needed multiple surgical interventions. So he was not quite well, but not quite severe. And on doing the genetic testing, we often do your child and you do the mom and the dad so that we can get a better idea of what's going on. And the dad was actually found to have a mutation. So a lot of functional testing went into this, looking at the mutation. And they both had a SIK or SYK mutation. There's a number of these that have been described now in the literature, and a lot of functional testing being done in our lab at the moment, trying to understand its pathology. But what is great about this, and a lot of work done in mouse models, so it has a lot of arthritis and gene issues and skin issues. And you see these arthritic features in your mice models as well, with them having particularly arthritic joints. And while our dad and child did not have the arthritis phenotype, many of the others do. But what was interesting is that there's a really easy treatment, and it's an oral treatment. The child had gone stem cell transplant already, and the dad was started on treatment and is doing well. But it shows that, and had he not been treated, they often end up getting cancers later in life. So just understanding and knowing the clinical diagnosis in both the child and then exploring the dad, we were able to identify these cases of rather softer phenotypes that may not have as much penetrance in your adult, in some adults, but can have different penetrance in children. It's something to think about when you have adults that are just not responding well to your treatments, or you've tried a number of treatments. Those who have atypical features, such as, I seem to have lost my last slide, I apologize. Those that have atypical features, so autoimmune profiles or a thyroid disease or any epithelial phenotypes, things that are just not making sense, may be useful to have a closer look. But particularly in children, and particularly those less than 6, have been found to have a higher incidence of monogenic disease. So about 5% of children less than 6, and in those less than 2, about 40% of those ended up having a defined monogenic cause. And many of them are actionable. And if picked up early, would actually reduce our financial burden quite significantly. So there's a number of American studies that looked at the amount of money used in terms of investigating TBN, surgeries, multiple hospital admissions, and weighed up the cost of multiple admissions versus genetic testing, and the role that it can play. So at the moment, hopefully with our pilot study through Red Cross, we will be able to form this bioinformatics pipeline locally using the South African Medical Research Council. It's an amazing genome center, which I had to come all the way to Canada to discover on that side, who does whole exome and whole genome sequencing. The idea is that they would share data then with the Muse Lab, which I'm currently working in, and we will be able to do a lot of then the functional testing, which is the more complex and advanced testing and requires more advanced labs to do. And we'll be able to better phenotype and genotype our population, understand how South Africans are different, what makes us unique, why do we have less dramatic forms of IBD or more dramatic forms, and how our infection exposure then either protects us or reveals our IBD, as there are a number of genes, just like SYK, which is actually triggered after an infective process. So I thought I'd leave some time for questions because there's a lot, and being able to go through all the treatment for monogenic IBDs is going to be a lecture on its own, and just management of VEOIBD. But I am happy to take questions now, or if you want any help with any of your patients, please feel free.
Thank you so much, Zeenat. I think I felt at times that you were speaking a foreign language with all these diseases that we probably are seeing but aren't identifying. So yeah, thank you for, it seems like you're still very much South African and that you want to come back. So we're very pleased to hear that. There's a few questions from Innocent, who's asking about adults. And his first question is, IBD involving the upper GI and perianal disease remain a challenge in terms of management, even in adults. Is there a specific genetic profile in the adult cohorts? Are they different to the peds cases that you talked about?
Yeah, so that's an excellent question. I think at the moment, the adult profile is still pretty much polygenic. There's a lot of work being done here. So they have a massive amount of funds, so which is great, and we're going to utilize their research capabilities. And they've looked at patients and their siblings and their parents and the entire family, looking at cohorts and what may be causality in terms of diet exposure, genetics, triggers. What we find is that the monogenic form of IBD is most studied in children because that's where they present a lot more dramatically. The adult cases we are finding more incidentally because we are testing the parents or families of these children. There is some work, but it's difficult to motivate from a financial standpoint doing genetic testing in general in the adult population. So it's difficult to really profile that as an adult. It's better profiled in pediatrics.
Okay, I think his other question is specifically for you rich people. He's wondering about if RBS patients could benefit from phenotyping, or do you have any thought on this?
There's definitely different penetrance in terms of these monogenic diseases. So like you saw in the SYK case, the child had a very dramatic presentation, but the dad thought he had IBS with these non-specific ongoing symptoms that he just lived with. And I guess it boils down to if they feel bothered enough by them, or they're presenting to you, it's something you can offer, but can it be routine care? Don't know if we would go that far just yet, but definitely something to think about in those chronic brewing patients that just not kind of going anywhere, or not really responding or partially responding.
Okay, great. Zeenat, there's a question from Sarah, who's a ped gastro and private in Johannesburg. And she's asking, in children below 6 with IBD, would you recommend a VEOIBD panel offered by Invitae, or would you rather go for a whole exome?
That's an excellent question. I think that the decision as to which genetic test you choose is very much based on how much funding you have and what's available to you. There's different ways. Maybe I should have touched on this. Like, you can either do a genetic panel, which is a predefined panel. This is often not the most updated panel, and the ones currently available do not have the full spectrum. Like I mentioned, there's over 100 monogenic diseases now, and over 70 congenital diarrhea. So they're not really covered in these panels. The difficulty with and then you have whole exome sequencing and then whole genome sequencing. Whole genome sequencing takes a lot longer and is a lot more expensive. And being able to interpret that data is not something that everyone is comfortable doing just yet. So whole exome is probably your best go-to. The reason we say that is because within your whole exome, you can do a targeted panel, but if you don't find anything, you can kind of go back and look at that data and try and look a little bit deeper, which is a lot of the project that we're doing, and we're going to be doing with Red Cross as well. Like looking at what we do know and then looking a little bit deeper to see, is there anything novel to our African population? So West sequencing is probably a better choice.
Yeah, I think we're not sure what mutations we have in our population, like you said. So we may not pick up much on the in vitro panel. I'm not sure. We haven't tried.
Yeah. It may not even be representative of our population.
Yeah. Penny, you've got a question. You can unmute, please.
Hi, Zeenat, thanks for a really fascinating talk. We do some genetic testing in our patients, and obviously if you find a mutation, it can be very helpful. But we have a boy at the moment who's a 2-year-old that we have diagnosed with either IPEX syndrome or an IPEX-like syndrome. And he had whole exome sequencing performed. And the only mutation was a mutation identified in the FOXP3 gene, but it's a variant of unknown significance. So we started him on prednisone and tacrolimus, and his histology is essentially unchanged: total villus atrophy, chronic inflammatory infiltrate, crypt hyperplasia, and he's completely dependent on parenteral nutrition. So we've been discussing a lot in terms of, should we go ahead with bone marrow transplantation, given the uncertainty of the diagnosis, because it's a variant of unknown significance, and it's possible we might go through bone marrow transplant and his clinical picture may not improve. So I'm wondering if you have any suggestions or leads for us in terms of, we've tried consulting and everyone seems to agree the mutation we found is a variant of unknown significance. We tried to look for staining that we could do. We haven't managed to source any through NHLS. So I don't know if you have any other suggestions in terms of how best we could confirm the diagnosis, because I think the decision has been made to go ahead with bone marrow transplant, but with a little bit of trepidation on our part.
Yeah, thanks, Penny. That's actually a very common scenario that we find ourselves in with these variants of unknown significance. Being here at Canada, we have that pleasure or that advantage of being able to functionally test these variants of unknown significance, which is part of the project that we're hoping to do. So we have the Canadians do all of our really expensive testing for us. But in these scenarios, I think it depends also on where the genetic testing was done. So different labs are able to look at different quality control measures a little bit differently in terms of what DNA results you get, which is why we're trying to set up the standardized bioinformatics pipeline with the South African Medical Research Council Genome Center, so that it's on the same standard as these international high advanced labs. Secondly, it's difficult when you have these clinical cases and it's just not quite sure. Doing usually your FOXP3 route, and a lot of those diseases do respond best to your stem cell transplant, and so that is often your route that you would go through. It does marry up things a little bit more at the end after the transplant, but it's one of those caveats where your hands are a little bit tied, and there isn't really no one would be able to confidently say 100% unless you knew the variant itself. The other option is just redoing the genetic testings at a alternate lab so that you have, a better spectrum of what's going on.
Yeah, I think the lab we did was pretty good, but I don't think our budget will allow us to retest, unfortunately. We've got very limited access to genetic testing.
Just getting the ethics sorted for Red Cross, and then we can send them over, hopefully. But yeah, it's difficult. It's difficult to say confidently, yes, go ahead with the stem cell transplant. Things are definitely going to get better, because you're in gray territory either way. And when you're faced with these clinical cases, trying weighing up a little bit individualist. Yeah.
Awesome. Thanks, Penny. I think it raises the question of what we do with our next very early onset IBD. Zeenat, can we contact you and send samples through Red Cross?
So at the moment, the study is set up to see Red Cross patients just because of the way it had to be set up and designed. it's a pilot study, so hopefully we can, generate enough data from this and then get more funding for more national exposure. So Ronaldo's probably the person to twist hands with, because she's my clinician, sending me, identifying the patients and managing them. But I'm really excited to be able to set up this process for us. And it's a process that we can use then in pediatrics and in adult cases, and on
Perfect.
advanced
Sounds
standards.
exciting.
Mm-hmm.
I don't see any other hands at the moment. Can I ask, if you've got a question, please raise your hand or type it in the chat before we say goodbye. So I think from my side, I just really want to thank you, Zeenat, for an excellent talk and giving us some food for thought. We obviously sitting on a number of these patients, and we're not managing to diagnose them. So there is another question. Sorry, let me read it properly. Is it best to do targeted gene testing, exome testing, or whole genome testing? I think you kind of have answered that, but you want to just highlight what the advantages of each is.
I mean, whole genome testing is the gold standard, because essentially you have a map of the entire gene, introns, exons, etc. So finding those genes that are often in those caveat areas between the two genes, you'll be able to highlight it. What we do here at SickKids is we do whole exome sequencing on all children. And if we still don't find anything on whole exome, or things are just not making sense, then we go on to do whole genome sequencing, because you're able to get those hiding genes between the two introns and exons, or deletions that are not picked up on whole exome sequencing. So if it's a very large deletion, we won't be able to pick it up on whole exome sequencing. There's a number of cases in my congenital diarrhea paper that hopefully will be published soon that will highlight this.
Awesome, and well done. Okay, I think I don't see any more hands. Shout if you are trying to raise a question. Otherwise, I just want to say a very big thank you again to Zeenat for agreeing to talk to us so early in her morning. Also, thank you to eEcho New Mexico and the eEcho India team that do the technical support. We will have a recording available on the Gastro Foundation website. And I also need to thank the Gastro Foundation and the sponsors. And for those of you who like endoscopy, next week's session will be on upper endoscopy, and we look forward to seeing you there. Thank you very much, Zeenat, and come back soon.